Restoring the pupil. Teaching pearls in iris repair. The pupil is not merely an opening in the iris, it's the eye's natural optical regulator. When disrupted by trauma, surgery, keratoplasty, or tissue loss, visual function deteriorates through glare, photophobia, and optical inefficiency. A systematic approach, selecting the right technique for the right pathology, allows us to restore clarity even in the most complex eyes. The guiding principle: center on the visual axis. The first principle of pupil restoration is centration, not on the anatomic defect but on the visual axis. The first Purkinje image provides a reliable intraoperative landmark. Every reconstruction must align with this axis because vision is determined not by where the iris appears center but by where the light enters the eye. Cerclage pupilloplasty is ideal in cases of diffuse atonic Iridodialysis syndrome and post-traumatic mydriasis. A long curve, a straight needle with a 9O or a 10O proline suture is preferred. Good coaxial illumination is essential to identify the Purkinje image in these cases. A continuous circumferential suture is passed through the mid-peripheral iris with evenly spaced bites. Gradual tightening of the suture allows controlled constriction of the pupil. Centration is repeatedly reassessed under coaxial light before final knotting. The trocar-assisted hangback technique. Iridodialysis is classified as massive, more than 120 degrees, moderate, which is between 45 and 120 degrees, and minimal, less than 45 degrees. Always remember to create a scleral pocket in the area of the dialysis and a clear corneal incision opposite to the zone of your dialysis. Now, a 10O double-armed proline suture is passed through the clear cornea, through the root of the iris, and exteriorized through the pocket using a 30-gauge needle. Once both arms of the needle are passed through the root, the suture is tied and buried in the scleral pocket. Now, the common issues we face in iridodialysis repair are the suture getting stuck within the layers of the cornea. To avoid this, we introduce the trocar-assisted iridodialysis repair. Here, we place a trocar opposite to the area of dialysis and the double-armed proline suture is passed through this. We notice the ease with which the suture slides in and then passes through the root of the iris. The hangback provides controlled positioning, particularly in fragile or fibrotic iris tissue. Horizontal or vertical single-pass 4-throw technique. The floppy iris and its constant billowing into the corneal incision is a surgical challenge. Now, the iris tissue in floppy iris behaves differently compared to normal tissue. Usually, the surgeons perform a horizontal iris repair wherein the 9O proline suture imbibes the atonic iris both proximally and distally. And this tissue has the tendency to get drawn towards the corneal wound. After the formation of the knot, the iris structure is still loose and the suture knot can be seen updrawn. This animation shows how the vertical SFT is being done for floppy iris. In this case, the iris tissue is pulled away from the corneal wound. Now, as the vertical repair is performed, usually twice, it engages the iris on either side of the corneal wound prolapse and it pulls the iris towards the center. This video shows a massive floppy iris and performing a vertical SFT in this case causes withdrawal of the iris from the corneal incisions and places it centrally. Now, a vertical iris repair in this patient engages the iris tissue and makes it taut and prevents its prolapse into the corneal incision. Prosthetic reconstruction. Iris prostheses are indicated in eyes with significant iris loss when primary iris repair is not possible, such as traumatic or congenital aniridia and surgical iris loss. Now, they are mainly classified into aniridic IOLs and capsular segment prostheses. Aniridic IOLs combine an intraocular lens with an artificial iris diaphragm and are ideal in aphakic eyes with near total iris deficiency. Now, Mosher's iris segments are modular capsular bag implants used to reconstruct partial or complete iris defects in eyes with an intact capsular support. Pinhole pupilloplasty. Pinhole pupilloplasty represents a fundamental shift in the approach to pupil restoration. In many complex cases, especially those with corneal scars or irregular optics, the limitation is not the iris structure but the compromised optical system. Historically, these cases were managed with keratoplasty. However, a global donor shortages leaves millions waiting, making alternative optical solutions essential. The pinhole pupilloplasty offers such a solution. Using a precise 4-throw pupilloplasty technique, the pupil is constricted to a physiological pinhole of approximately 1.5 to 2 mm. This approach works well for paracentral scars. However, when the scar is central, a decentered pinhole pupilloplasty is performed, strategically relocating the functional pupil towards a clearer optical zone. When the scar's paracentral, the pinhole is centered on the visual axis. However, in cases of central corneal scarring, the pinhole may be intentionally decentered to utilize a clearer optical zone. The principle behind decentered PPP is based on optical refinement and neural adaptation. By reducing the angular spread of incoming light rays, the pinhole pupilloplasty minimizes the blur circle, and over time, the photoreceptors functionally adapt to the new optical pathway. Its advantages are significant. It eliminates the dependence on donor tissue, technically efficient and reproducible, enables rapid and predictable visual rehabilitation, requires minimal postoperative therapy. Pinhole pupilloplasty shifts the focus from structural replacement to optical optimization, offering visual restoration through precise control of light. Successful pupil restoration depends on selecting the appropriate technique. Each technique addresses a different dimension of pupil dysfunction. Together, they form a complete surgical strategy.